we presented a case that was amazing, and we are publishing that with another similar case of a patient with recurrent angina. Recently, before she came eventually to see us, followed recently by ventricular fibrillation. She had 6 cardiac arrests, always preceded by chest pain. So she had an external defibrillator, and eventually came to me because the electrophysiologist was uncertain if he needed to have an implantable defibrillator or better to take care of spasm, because he thought that probably this was a spastic Prince-Metal angina type of presentation. So she came to see us, and she had a previous catheterization showing a muscular bridge of the LAD. She was taking a bunch of nitroglycerin to prevent spasm. That was partially effective, but it was not totally effective. So as by protocol, when we want to study these patients that are presumed to be Prince-Metal, we stop at least for 12 hours nitroglycerin. And she had chest pain before coming to the cath lab in the holding area. When she was in the cath lab, she had no pain, but the first injection showed 99% stenosis of the LAD, where before she was known to have a myocardial bridge. So we gave nitroglycerin, and the 99% stenosis disappeared. So we took pictures, and we wanted to be sure that this was reproducible. So we gave a little dosage of acetylcholine that caused exactly the same LAD subtotal occlusion, and we became quite adamant in claiming that this was an LAD myocardial bridge pretty much in the same area, close to the outflow tract of the right ventricle and immediately after the diagonal, that would cause myocardial bridges related spasticity, and the acetylcholine showed that there was no other section of the heart in this study that was showing spasticity. So it was an elective mid-LAD muscular bridge spasm. So after talking to the referring physician, who has also a myocardial bridge, and the family, we came up with the conclusion that this would be a good idea to treat with the bridging. And there is a very limited literature on what happens at the bridging, or unbridging a muscular bridge. But there are some disasters reported without a clear mechanism. This patient was done by Dr. Livesey, that was here when we presented the case, and he found at surgery a very thin myocardial bridge that at the time of surgery had a spasm, an indentation in the middle of the bridge. He cut it out. Even without myocardial bridge anymore, that segment of the LAD remained partially stenotic. She was given immediately after surgery a nitroglycerin patch, but developed hypotension, so much so that she eventually required vasopressors, inotropics. And during inotropic treatment, she developed ST elevation, both chest pain, she was already awake 2 hours after her procedure, and ST changes, ventricular tachycardia, and it was really bad. So much so that we resumed nitroglycerin, but 4 hours, 6 hours after the procedure, we did enzymes, and they showed severe elevation of troponin and CPK. So in the afternoon of the same day of the procedure, with persistent ST elevation, we studied the patient, and with angiograms, we saw severe LAD diffuse stenosis that reacted to nitroglycerin, but stenosis was also present in many other vessels in the circumflex, and they were relieved by nitroglycerin. So there was a sort of a tempest of spasticity from endothelial dysfunction that before we thought was only related to the LAD muscular bridge, but after surgery also in areas where there were no signs of myocardial bridges. She eventually developed a small scar. The ejection fraction from 65% went down to 38%, but 3 months after, she recovered normal left ventricular function, and she's totally asymptomatic without nitroglycerin now a year after the procedure. So there can be endothelial dysfunction with or without myocardial bridges, but the myocardial bridges probably more selectively at that level, and obviously after surgery it is a worry. She behaved like a Takatsubo,
Right.
kinesia type of presentation after
Right.
surgery.
But also they were giving her inotropes, right? So that could have induced the spasm.
Right. That was stopped, and eventually nitroglycerin probably was the critical change that smoothed out the recovery. But for the first 24 hours, she looked very, very sick.
So is your preference to do surgical myectomy in these patients or stent the myocardial bridge?
Well, there are problems with both. If you stented, that guy that was quoted before, Mockendorf, the German cardiologist, published his experience with stents in myocardial bridges, and they reported 50% of restenosis. With
Yes, but that, first of all, that was before drug-eluting stents, wasn't it? And then second of all, if they put a second stent in, the patients did very well.
Yeah. So in the bridging, I was never exposed to a similar horrendous postoperative, but in the literature there are some cases that had myocardial infarction after the bridging. I don't know if this can be prevented, but this patient that we did was obviously quite endothelial dysfunction related symptomatic. She must have had a lot of endothelial dysfunction to develop eventually all these complications, but she did very well since. She is now totally asymptomatic without nitroglycerin, only with arginine. Arginine could be helpful if there is a nitric oxide deficiency.
All right, well, I could try that in this patient because she continues to have chest pain.
Ah, yeah, it could
So
be.
I was assuming that it was the distal LAD that just is such a small vessel,
It
but
could
maybe
be
she has...
that if she has another occasion to come to the cath lab, I would do the test both with nitroglycerin to know what is the baseline real lumen, and then acetylcholine to see if there is a component of endothelial dysfunction.
Okay. How long after you give nitroglycerin do you have to wait before you can give the acetylcholine?
In 3 minutes, the patients they are positive to acetylcholine, nitroglycerin effect disappears.
Mm-hmm.
You eliminate the spastic reaction, and in 3 minutes you can do it again and have it again. It's very interesting pathology.
Okay, so you said 3 minutes after nitro.
3 minutes is the time that the nitro has effect.
So you wait about 10 minutes.
Yeah, well, even less. 5 minutes is more than enough.
Okay.
Basically, the intracoronary nitroglycerin has local effect of the first passage, but not systemic effect.
Mm-hmm. Very good. All right, thanks, Paolo. Because the other thing that I've been thinking about with this lady is to put her in a stem cell study.
Yeah, it could be. Before doing that, I would suggest you what I did in 2 patients with Prince metal angina. They would not be relieved by association both of beta blockers, calcium antagonist and nitrous. And in that patient, we used a spinal stimulator. Medtronic and others make stimulators for prolonged chest, for pain, chronic pain. And in the heart segment, you go to the cervical spine segment with the stimulator. And these patients react very well. You instruct them to turn on the stimulator during the chest pain at the very beginning, and the pain stops immediately.
Yeah, I've used TENS in other patients. I hadn't thought about it in this one, but that's something we could try.
It could be.
And also the arginine. Okay.
Yeah.
Thank you.
Very good.
I have another case, unless somebody else does.
Let's do it.
Okay.
Go ahead. Go ahead, Paulo. Go ahead, John.
Okay, let me get rid of this. Can I have control of my computer? What's going on? I wanted to get rid of that. Okay, let me just bring up this PowerPoint. So how do I get this? There we go. All right, so this is an anomalous left coronary artery in a patient who had a heart transplant. And so the transplanted artery had this anomaly. And that
was it noticed by the surgeon?
I don't know that. The transplant was done at another hospital.
Okay.
And now this patient has come to us. The transplant was done in 2010, I believe. And and now is being followed at UCLA. So the May of 2010 is when the patient had the transplant. And I think we can just go to here, let me do the slideshow.
Clinically,
well, clinically the patient's doing well, not having angina. This patient was coming back now for their annual coronary angiogram.
All right.
Okay, and I didn't do it. One of the other physicians here did it.
It's another coronary anomaly. It was a split right, but that is not important.
It's running kind of slow. I'm not quite sure why, but there you can see the left coronary artery. Let me see the next one.
So it's almost from the right. It's probably a niche that has both the ostium of the right and the LAD.
Yeah, I think you can see both the ostiums are coming off right next to each other.
It's LAD and circumflex, or only LAD and diagonal ramus?
I think that's all there is from that's feeding the left side.
What would you call the LAD? Is the first branch the thin one?
Yeah, I think that's what we're calling it.
Do you have doubt about the course of this artery? The big question is if the course is intramural aortic or intraseptal infundibular, which is benign.
Yeah. So the person who did this study did not do intravascular ultrasound, and so that's one of the questions for you. Would you do that next time? I don't know how old the heart was that for the transplant, but presumably we should be able to get that information and whether that makes any difference or not. And since these people are denervated, I'm not sure that the patient would have any angina even if they were ischemic. On the other hand, they're a transplant patient and probably not going to exert themselves very much.
Yeah, angina can occur after a few years because they develop new innervation. But at the
Yes.
beginning, they will not have, they have sudden death when they develop coronary disease of transplant rejection
Mm-hmm.
at the coronary level. You see here, you have a very good picture that shows exactly the situation. In a mild, this is almost PA cranial. PA cranial. The first branch anteriorly is a small LAD. Basically, this heart was born without definite LAD. The vessels crossed the anterior interventricular groove, but the first branch of this anterior bifurcation of this branch to the left is a septal, and it should be called LAD, even though it's a very small LAD. And the rest is ramus and a little circumflex. The right is very dominant and had an anomaly with a split pattern of right coronary artery, very dominant. But this is definitely the kind of left main from the right that goes infundibular, is benign, gives the first septal as the first branch, and they may have myocardial bridge behavior because it's intramyocardial at the upper segment of the ventricular septum.
And so you don't think it's necessary to do IVUS and see what the entrance looks like, whether it's slit-like or not?
By CAT scan, you can confirm this very clearly. I don't know if you have all the images, but this should tell you very clearly that this is not intramyocardial. Mm-hmm. If you want to return to the pictures in the angiogram, when you have a right anterior oblique projection, straight RAO.
That's LAO. Here's the RAO. Which projection did you want?
This is almost PA. The descending aorta is over the sternal wires. A right anterior oblique you don't have. I think you had it at the beginning.
This is RAO. The 19 degrees RAO projection.
Okay.
The question is, how do I get it to play?
It does. But this is the right.
I think maybe I should go out and then play it again. Let's see, how do I get out of here?
Okay. See, this is almost PA. It doesn't show very well, but think of where the aorta will be in this projection. The aorta will be from the tip of the catheter up straight following the catheter, the body of the catheter. So the left main, LAD, and circumflex branches that subdivide very early in this case, which is unusual, go away from the aortic wall. They don't follow the aortic wall as in intramural course. In intramural course, you will see the proximal LAD, left main, going around the aortic wall, making a C, an inverted C. So this is definitely infundibular course below the pulmonary valve and in the upper ventricular septum.
Okay.
So this is benign and it will not cause chest pain usually. We have seen a patient, I don't know if you remember, a soccer player that was disqualified for professional sports in Spain. They was sent here for a final opinion on the presence or not of disqualifying the lesion. He was told in Europe by different experts that he had a left from the right, and that by itself was disqualifying, and so he lost 45 million euros contract. But he had this kind of left from the right. It was infundibular, not intramural. There was no compression around the aorta, no intramural course. And in that patient, acetylcholine caused spasm. So the intramural segment is again, intramyocardial vessel is again showing a tendency to have endothelial dysfunction that is interesting.
So that's interesting. So you're using acetylcholine now on your congenital anomalies?
Especially when there is a chest pain and an intramural course of any kind. Because people in Korea showed very solid evidence. I think it's 145 cases of muscular bridges where they systematically did the acetylcholine test, and 50% of the patient had more than 50% stenosis caused by the acetylcholine at the level of the myocardial bridge and nowhere else.
But your soccer player, it wasn't a myocardial bridge. You're saying it was the initial portion of the anomalous coronary that's going through the wall of the aorta.
You see, in this view, you will see in the first 2 centimeters, the coronary artery is in the crista, in the right ventricular myocardium, and eventually is the upper ventricular septum, so intramyocardial. But this kind of intramyocardial course usually does not cause spasm because it's way inside the ventricle. It's not subepicardial. But in that patient, the spasm was more in the right ventricular myocardium, right ventricular crista segment at the beginning of the left from the right that was causing in with acetylcholine some spasm. He did very well to continue his career. I don't know what happened this year. Is 2 years after he moved from one team to another. I don't know for what reason, but he had for 1 year a monitor, implantable monitor that never showed any arrhythmias. He was considered to be a normal soccer player, very active, good runner, good athlete, and nothing happened. He never had any symptoms, but he had this routine screening by CAT scan because of inversion of the T waves at the screening when he had a new contract when he passed from one team to another, and that would caused all the problem.
So what portion of his $45 million contract did he give to you?
He paid $250 for the visit.
Well, at least he paid his bill.
But he sent me a beautiful T-shirt.
Well, that's worth it, right? Very good. All right, thank you, Paolo, for
That was
reviewing
very
that.
good session, very good. Dr. Morales, congratulations. Good presentation.
Thank you, Dr. Angelini. I'll see you over there in Methodist. I'm on my way there tomorrow.
All right. I want to see you.
All right, I'll stop by and say hi.
All right.
Take care. Bye-bye.
Bye-bye.
Bye,
Bye-bye.
Bye,
Paolo.
Bye,
Bye,
Paolo.
John. You guys take care.
Yeah. And Paolo, it's good to see you up and running around.
All right, thank you. In great
Okay,
shape.
take care. Bye.